This is where the future begins. It's time to invest in our future. It's time to help our schools improve for the future. And it's time to give our educators what they need to innovate for the future. Because the future of Texas is in our public schools.
Public dialogue and civic engagement play an important role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is a proud supporter of free Texas Tribune events like the conversation you're about to see.
My first question for you is, U.S. healthcare spending is somewhere around $10,000 or $11,000 per person, or about 1/5 of U.S. GDP. Too high, just right, could be higher?
Way too high.
Okay.
Entirely too high.
Ms. Kirsch?
Too high. Too high.
Why don't make it unanimous? Too high.
Okay, fantastic. Good starting point. We're all in agreement. Okay, next question. Should healthcare be a human right? Mr. Ballat. And I promise I'll give you a chance to explain later. But for now, yes or no?
It is a human right.
Is it a human right, Ms. Kirsch?
Absolutely. Yes.
4 in a row, yes.
All right, last question. Should health insurance coverage be a human right?
Absolutely not.
I think we should strive for for everybody having coverage. No.
I believe access, I don't know about insurance, but I believe access should be a human right.
Great. I wanted to start with that. I think it's important to acknowledge that
I believe
across our great state.
The U.S. economy, but there are different objectives, policy objectives, and when we're talking about cutting costs, not everybody has the same goals in mind, and I think it's important to sort of start the conversation from there. Representative Lucio, I was hoping we might begin the conversation with you. Given your position on this newly formed select committee, how ambitious is the state of Texas going to be in 2021 when it comes to actually doing something about healthcare costs? Like, what is actually on the table?
Well, I'll tell you, I also serve on the Public Health Committee in the legislature, and I chair the Insurance Committee, which oversees health insurance and windstorm insurance and many other insurances, all the insurances you can categorize in Texas. And what I see is a shift towards a patient-centric regulatory structure in Texas. You know, we passed a surprise billing bill in Texas, which I think the climate for that would have been very different 10 years ago, 15 years ago, but essentially taking the patient out of the equation and requiring, hospital providers and insurance companies to discuss any unpaid medical bills when someone leaves the hospital with insurance. It made me very optimistic that from a regulatory standpoint and a policy-making standpoint, that state lawmakers are really focused on the patient. And hearing bill after bill, whether it was Democrat or Republican, trying to create more coverage for patients for specific conditions that historically have not been covered, and with a wide range of those conditions, from cancer patients having coverage for wigs during their chemo treatment to, one was before a man is diagnosed with some cancer that is going to hurt his fertility, paying for access to store that have not been covered. The utilization when he's ready to have kids, and I thought those were amazing. The push is for more access, more patient coverage.
And it was a push, right? I mean, you took heat from providers in that process. I mean, that wasn't an easy bill to pass.
The providers wanted to make sure that the structure was set up in a way that provided equity and fairness when the negotiations began. But they never said, no, we want patients to pay. No, it was always more about the process than the merits of what we were trying to do.
I think it's an important point, looking at sort of the patient-centric model. It also makes me think of the fact that in the United States and as well as in Texas, I think patients are bearing more and more, or being asked to shoulder more costs, whether that's through increased premiums or higher deductibles in their insurance plans. And I was just curious, a question for the rest of the panel: how much more can we actually expect patients to carry the load when it comes to, costs and, co-insurance, et cetera?
Currently, they bear most of the brunt of the load. Insurance is there to transfer risk, and currently, with the average American family covering $20,000 premium expense a year, not to mention the $4,000 to $6,000 deductible on the low side, there's no real transfer of risk there, and Americans are suffering, and they're avoiding treatment and avoiding preventative care. Because they're afraid of what the bill will look like when they get to the doctor's office. We don't know what the prices are up front, so that's something that prevents us from getting the care that we need.
I agree. I was reading last night, for the typical Texas family, their own cost for premiums and deductibles is over 13% of the median income in Texas, so over $8,000 for a family. And that's been going up and up every year. And I do think that, as Mr. Balot said, people are avoiding care. They're avoiding necessary primary care, preventive care, chronic care management, and that leads to higher costs down the road if people aren't able to manage and prevent chronic conditions.
I think we all agree with that. If you look at the United States overall, households bear about 30% of the cost. And then, the employers through carry insurance are at 20%. I was a little surprised to see that number. They can't afford it. And I would agree wholeheartedly that they delay care because, they can't pay the $5,000 deductible. And I think we as a society and we as a community have got to, as we transform, in the U.S. and in South Texas in particular, we've got to get them in for that preventive care because we're all paying for it on the back end.
What is a good number if 30% is too high? I mean, is that possible to answer?
I have no idea.
And let me just kind of highlight something. I had an interesting conversation with the State Realtors Association yesterday. They came down and they were talking about the rising costs of real estate and how for many years, decades, the rising cost of real estate was at par with the cost of the rising cost of income. Or the rising income levels of Texans. So as real estate became more expensive, we made more money and we could stay on par and afford buying homes and so on and so forth. But in the last decade, there's this huge disconnect. So real estate becomes more expensive, but our income isn't growing at the same rate. So now home ownership is going to be out of the reach of younger Texans. And we have a demographic that's getting younger here. Now, couple that with, our income isn't rising to keep at par with the rising cost of healthcare and the rising cost of home ownership and the just general cost of living. So we have a systemic problem well beyond just healthcare with affordability, quality of life in our state.
And if I may just add to that, an important thing to take note of is even with incomes that are rising, you look at a lot of our teachers that are suffering. With the raises they get, they're actually taking a net loss because of the increase in their health care benefits. The same thing happens to our seniors whenever they get a cost of living increase. Medicare is a little bit bigger of a hit, and they're taking a loss, and they're on fixed income, so it's very difficult for them.
So I want to return to that point, Representative Lucio, because I think it's a very interesting comparison. Looking back at the 2019 session, we heard nonstop about home ownership and affordability in the context of property tax cuts. It was a tremendous priority for the legislature. A lot of my sources in healthcare world were kind of feeling neglected last session, essentially saying, we've also got a crisis on our hands, an affordability crisis. Where's the attention? And so I just wanted to ask, in 2021, do we expect, is there going to be a greater focus on healthcare?
Absolutely. But you remember in the state of Texas, we only regulate the commercial market 13% of all insurance provided to in the commercial market. The rest of it is regulated by the federal government, or at least there's this understanding, not yet tested, that 87% of the market should only be regulated by the federal government. A lot of what we can control is Medicaid-based insurance, and we heavily regulate there, and I think contain costs better there. And I think there will continue to be, look, in full disclosure, transparency, I own gyms, right? I'm a lawyer, but I own Orange Theory Fitness in Brownsville and Harlingen. So I don't say this is self-serving, but the only way that I see making a dent in the rising cost of healthcare is in preventative care. And I see my kids' generation as the first to live a shorter life expectancy. At least that's what experts are publishing, because they're so unhealthy. And we're cutting PE programs to have more rigor on academics, which is, great on one end. We're going to produce more college-ready students, but they may be very unhealthy. So when I am promoting health and wellness, I talk about starting fitness and nutrition early, and that's where I'm going with the select committee on studying the costs of rising healthcare.
Your point about the state's role in insurance regulation is well taken. It's a small, comparatively, share of the market, but I want to push back on the idea that there's not a lot that states can do, in the sense that in other states, I'm thinking of Colorado as an example, there have been bipartisan efforts looking at hospital costs in particular, and price transparency. Ms. Kirsch, I know this is kind of an interest in yours. I was curious if you see models, from around the country that Texas could be following, or positive examples as far as, reining in costs.
Well, absolutely. I mean, and I think there's a lot of efforts, and there have been some here too around price transparency, which I think is a piece of the puzzle. If you look at the data, the two areas where costs have risen the most, and they've risen quite a bit, is hospital care and drug prices. And we hear probably more about drug prices. So yes, I think the federal government is making some attempts at some transparency in both of those areas. I think other states have done more than Texas, although I think Texas has taken some steps to try to deal with that as well. If we don't know what we're buying, and this goes for employers, it goes for individuals, how can you make a good choice? And I think about a while back, I was offered an allergy eye drop, and I gave me a coupon. I went to the pharmacy. It was only going to be $20 for me. And then when I got to the pharmacy, they said it's $100, and it was this tiny little vial. And I said $100, and they said your insurance already paid $100. And I said, this is $200 for this tiny. I don't want it. I'll go to Target and get the generic for $17. My allergies aren't that bad, but people who are buying healthcare, we don't know what it costs. And so how can you make a good decision if you don't know what you're buying? And you're also, often we don't know about quality, which is a whole other question of, you asked about appropriate costs, and a piece of it is cost, but it's also, are we getting good health and good care for what we're paying? And that's extremely important, not just what you're paying, but what you're getting for it. And we don't do so well there either.
I'd like to add to that, from a provider standpoint, I think everyone in the community is very supportive of transparency and cost. It's extremely difficult, however, to broad brush that, because when you come to the hospital, if I know I can't give you a price, you can't Google it on the internet. I need to know exactly what procedure you're going to have done and how you're going to be treated, and then absolutely I can give you a price. So it's got to be more individualized, I think, as a nation. If we start publishing pricing on the internet without having a person-to-person conversation with that patient, they're going to be more confused than from when they started, because it's complicated. It's not, if I bill a surgery, I could bill one code, I could bill 10 codes, depending upon how it's done. And, the way our healthcare payment system has just, morphed over the years, it makes it more and more difficult. But absolutely, on a one-on-one basis, we are absolutely in favor of price transparency. It's just not easy to do.
We heard a lot of testimony on that. So imagine going into the hospital. It's an emergency. You're sick. You're real sick. You're barely able to communicate with the loved one that drove you there. And you go in, and typically they need to make, get you in the room and get you stable before you can even have a coherent conversation. So you're checking in at the front desk. You're giving them your information. You're being admitted. You're not in the right frame of mind to go over a menu of things, nor is that person at the front desk aware of what services you might ultimately need because they haven't diagnosed you with anything. So it is complicated. It would be great to be like you're walking into a restaurant and saying, well, this is what I choose to have. But it's very complicated in an emergency room setting at least, right? Maybe in a clinic setting where, you don't need to immediately be triaged. But I heard from providers and from hospitals, it might be a deterrent. So someone's going there with chest pains. Now they're having a conversation about costs, and they just say, well, I can't afford that. And they walk out and they die on the way home. It's interesting. I think we need to have transparency and maybe, have consistent billing, after the fact. But to have that conversation transparency at the point of admission is dangerous to an extent and complicated.
In the ER, absolutely, but a great percentage of healthcare is shoppable. And the importance of having those prices up front isn't necessarily when you're there for the service. It's in advance if you have something that you're planning that is elective. Being able to to identify what the prices are. Let's just take something simple like a CAT scan. If I have remaining $2,000 on my deductible, and hospital A has a negotiated rate of $1,000 and hospital B has a negotiated rate of $2,000, I'm going to be paying my $1,000 plus some to hospital B. I should know that ahead of time. I should know what my expenditures are going to be. And so that's what the transparency is seeking to give consumers the ability to make a decision and a choice.
Yeah. I will say, in my personal experience, it's been difficult to shop around because just the amount of work that it takes, trying to have some kind of procedure, an MRI or whatever, scheduled, and calling providers and saying, how much is this going to cost me, is difficult. And I think it's fair to expect that that level of effort is maybe not something you can expect from every patient. And so I was curious, Ms. Turley, you talked a little bit about the idea of price transparency, disclosures in these one-on-one settings. How does that work from your perspective as a provider, and where do you see room for improvement?
We often do this. We have patients who come who, particularly this time of year, because they haven't met their deductibles. And we have that one-on-one conversation with them. One of the players that often gets left out of this conversation, if they're insured, is the carrier. Because, a patient has a contract with Insurance A, and Insurance A has all of the information about their negotiated rates with every provider in the community. And so I think that insurer needs to be part of this conversation, because they're asking a provider to understand exactly the policy that this patient is covered under, which is difficult. And so, what I think we can do better is to have a better collaboration up front between the patient, the insurer, and the provider, so we are able to communicate, better information to the patient before service.
We've got, a couple, big picture thinkers up here, and we've got a legislator and on a committee in a position to tackle these very issues. I was just curious if each of you had the opportunity to make one recommendation to the select committee to study over the interim, or to become legislation in 2021, but you only had one recommendation that you could make. What reform would have the single biggest impact on cost containment in Texas? Like, what's the one thing lawmakers should look at if they don't look at anything else? And Mr. Ballad, I'll start with you.
Healthcare is so complex and multifaceted. One, I'm afraid wouldn't do it. But in line with what we were saying, I think transparency, especially in state, what we can do in the state, I think that would have a big impact in bringing more light to the pharmaceutical supply chain, the hospitals, physicians, the carriers, just the entire industry.
It's tough to come to one. I would say step back, and you're going to hear later today from Elena Marks with the Episcopal Health Foundation, who's they're really focused on health and root causes of poor health. There's another organization called Texas 2036 that I want to make you aware of if you're not, that is really looking at what are the underlying factors that are leading to poor health and high costs in Texas. And as a state, so that we can be successful in 2036, what do we need to be looking at to keep Texas on top and to keep Texas successful? So I think those root causes of poor health, and in this part of the state where you do have a very young population, what we can do with young children, with young people, is going to make a huge difference for costs down the road for Texas. So and I know that the price transparency and hospital costs and drug costs and insurance, all of that is really important. But if we don't look at what is causing us not to be healthy and address some of those things, all of this becomes much more difficult.
100% second what Lisa said. The state of Texas has got to address chronic illness. If we don't address chronic illness, and this starts at birth, it's a never-ending spiral of additional costs. And, the Valley has, unfortunately, one of the highest rates of obesity, I think, in the country. If we don't get a handle on that and the downstream impacts of lifestyle, I can tell a patient all day long how much it's going to cost them to get treated, but that does nothing to bend the curve on lowering the cost, both for them personally on their out-of-pocket, for their employer, and ultimately for the taxpayers.
We are already having very deep, very thorough conversations on transparency, access to affordable health care, containing costs, drug transparency, transparency with providers, insurance reform, all of those things. Those are at the forefront of our conversations on both committees, or now 3 committees I sit on. What we don't have a handle on, and it's in its infancy in discussion, is preventative care, right? I was an overweight kid, and I remember not feeling great about myself, but what really kind of struck me was all the adults, influencers in my life, were having heart surgery, were multiple heart attacks. All 4 of my grandparents had some form of heart procedure, and I remember thinking, well, I see them eating. They eat horribly. My grandfather stopped, moving as soon as he retired in his early 60s, lived the last 30 years of his life in just pain as a diabetes patient, heart patient. So I said, I better get healthy. And that was a 16-year-old me speaking. And, I thank God have continued that lifestyle. Now my 10-year-old works out with me regularly, and she's seen that. And we need to study root causes of healthcare. But I know now from personal experience and in the work I do in fitness that we can have an immediate, profound impact if we can somehow incentivize exercise and healthy eating, right? Because there is no incentive there. But there's very few programs that we offer that really incentivize healthy lifestyles.
And I think of that not just in terms of incentives, but sometimes even ability. So, personal example, but last night, my hotel, I needed something for dinner. I, look online. There's several restaurants within a 15-minute walk from me. I think, great. I've, been on a plane all day. Maybe I can stretch my legs, get 15 minutes of mild exercise. And then I learned that the pedestrian experience was lacking, shall we say. And that boils down to a government decision, right? Like that is a government not prioritizing dollars for sidewalks or what have you. And what I'm getting at is when we talk about root causes of health and primary care, et cetera, we're not just looking at like Article 2 Health and Human Services portion of the budget. And so I wonder, is there a way to take this sort of massive pot of healthcare funding that we have in this state or in the country in general and rework other sort of separate articles that we might think about, transportation, the environment, et cetera, in a way that actually could improve people's health? Like, is there a public health committee?
It's happening. Let me assure you, the hike and bike trail system in the Rio Grande Valley, where we had the largest rate of obesity in the country, is excellent. Brownsville, Texas, San Benito, Harlingen, just the areas I represent have very nice hike and bike trails, a lot of access. I ran the McAllen Marathon 2 weeks ago. It was a fantastic event, very well attended. So we're trending in the right direction. Communities, local governments, not only at the city but the county level, are looking at connectivity, not just mobilization through buses, but also are we connecting our hike and bike trails to where people can ride a bike to work or school? So I will tell you, and Bike Texas and all the other organizations that are getting involved, I mean, that part of the equation is definitely being monitored and worked on.
But they need money to do that. And I guess my question is there a case to be made that healthcare money should be going toward that? And for the policy thinkers here, I'm curious about your response to that. I see Ms. Kirsch, you nodding.
I think this is really difficult to do. You have federal agencies that are funding health. You have federal agencies that are funding mental health, SNAP, food assistance, housing. And yes, I think there's a growing awareness that all of us need to be working together and across those funding streams. Now, saying that is easy for me to do. Actually getting those agencies to be thinking more holistically about if someone doesn't have a home or doesn't have a safe home, it's going to be hard for them to be healthy. That's a really important question. And I guess I am heartened by the fact that I think locally, I think at the state level, and I think at the national level, we are having more and more of that conversation. Last fall, Alex Azar, the Secretary of Health and Human Services, had a speech that kind of shocked me, where he said, if we do not let our Medicare health plans, the Medicare Advantage plans, address root causes of poor health, like housing, like food, safety, then we can't help our Medicare patients be healthy. And so Medicare has given their health plans latitude to pay for some things that they never paid for before. So if they want to pay for targeted medical food for someone with diabetes, a Medicare health plan can now. And we're starting to see a little bit of that in Texas Medicaid too, where there's an acknowledgement of the plans having a little bit more flexibility. So I think we're dipping our toe in the water, but like everything in healthcare, like you said, the way the system has evolved, it's so complex and you have so many players that anything you do that someone thinks could, frankly, and I understand this, it could change their income, it could change their business model. People are reluctant to change. And so it's gonna take a pretty big push from a lot of us, I think, to get what you're talking about to happen.
I think it's important to make a distinction between health, healthcare, and health insurance. Too often, those three terms are conflated and confused. And earlier, the question of is healthcare a human right? And I said yes, and because so is food, so is clean water. But that doesn't necessarily mean that has to be something that is given to us. That's something that we should strive to achieve for ourselves and have that personal responsibility to care for ourselves and for our families. Where we've gone wrong in healthcare is healthcare is ultimately about the doctor-patient relationship. And what we've seen over the last 10, 20, 30, 60 years is that there have been more and more middlemen that have come between the two parties in that relationship. They're extracting value and resources from the overall system, making the system more expensive. We need to get back to having a relationship with our physician. I use something called direct primary care. I have a very good relationship with my doctor. He has no problem telling me that I'm a little overweight. We have that kind of relationship where it's like, Dave, you need to stop buying as many groceries. And I don't necessarily like hearing that, but it's good to have that conversation with somebody who's going to see me more than 3 to 5 minutes with his back towards me, punching into a computer. We've got to get away from that environment that we have today to where doctors are invested in the lives of our patients, because what we have today is not healthcare, it is sick care. We have a reactive system. And as Ms. Turley was talking about with the coding, codes are a response to what is occurring. There's no reimbursement methodology that focuses on wellness and preventative care that really works well.
And I would just add to that, I think there's a lot of how we get paid is really important, how doctors get paid, how hospitals get paid. And if you're getting paid for one more MRI, then everybody's in healthcare because they want to deliver good healthcare, but the incentives are to code, to bill. That's how you're getting paid. So one of the big things the Dell Medical School is focused on, and Medicare's looking at this too and other payers, is how do we pay doctors and hospitals and health systems differently so that they are rewarded for delivering high value care that is getting to good patient outcomes and that also is as cost effective as possible. This is not an easy thing to figure out, but there are also a lot of people working on that. And I think that's where the focus should be is, are we giving people what they need to be as healthy as possible and in a cost effective way?
I would like to add to that. The state of Texas, through its Medicaid programs and managed Medicaid programs, you're going to see a transition over the next 2 years to where a larger piece of what everyone gets paid is going to be based on outcomes, not on lab tests and diagnostic tests. And, was the intervention that you did you achieve reducing A1C values, whatever that quality metric may be. And, the state is working very diligently with all players in the healthcare arena on how do we best do that to serve, the patients. And I also think, to your point, private-public partnerships are key. In McAllen, we're very fortunate in that, we are in the infancy stage of developing Boys and Girls Club, the McAllen ISD, Foundation Board. We've identified an area in South McAllen, they have no access to fresh food, none. And doing a community garden that brings that there, that will distribute these to the families who are in need. And if you start that in grade school, it becomes ingrained, and that's going to have a much more positive impact on our community and their lives. And so it's not just insurance, and it's really a much broader picture.
I wanted to follow up, Ms. Turley, with a question about the sort of value-based purchasing side of things. From a provider's perspective, I'm just curious, we try to assign these metrics that say, right, we're going to pay you if you have a good outcome, and what defines a good outcome will be, a metric. But I think all metrics and all sort of standardized scoring, has its own pitfalls. And I was just curious, from the provider side of things, do you feel like where we are today, we are effectively measuring outcomes, or if there's room for improvement on that side of things?
I think right now we're doing the best that we know how to capture the data. You know, answering the question, did my treatment result in a better health outcome, is so multifactorial. And the patients have such a large responsibility in, you know, I can do a lot of different things, but if they're at home eating 3 bags of Doritos and, you know, how can you pinpoint what intervention may or may not have made that impact? It's tough. We're working on it. I mean, you know, the state of Texas is working really, really hard as we transition to, you know, the new Medicaid plan on how we best do that. And we're not going to get it right the first time. But I think it will evolve over time to where we're able to better measure how did we, whether you're a physician or a hospital or you know, a home health care agency, did we positively impact that person's life and that person's health? Do I think we're there now? No. Do I think we're doing our best to figure out how to get there? Yes.
Representative Lucio, I want to ask you about the politics of these discussions, because there are a lot of them. And, you know, when we're talking about healthcare, we're talking about, again, a fifth of the U.S. economy. We're talking about tons of jobs. You know, we talk about stakeholders. I mean, there are literally millions of people who have stakes in these decisions. Where do you see sort of bipartisan interest at the Texas legislature? Like, where do you see actual likely reforms coming? You mentioned surprise billing. It was a bipartisan effort. But looking ahead to next session, what else is there that the folks in the room actually agree on?
There's so many components that contribute to the cost of healthcare, right? We had a PBM, prescription drug management, pharmacy, independent pharmacy bill, and I said, well, I'm going to call a few stakeholders in so that we can have an initial conversation, so I can learn, as now chair of insurance, how that whole industry works. And what I thought was going to be a handful of people turned into a 75-person stakeholder meeting in a room. And then we started to chart out all the different people involved in the prescription drug insurance industry. And it was very interesting. It looked like scribble. It looked like something out of, you know, Wile E. Coyote map. But what I will say is transparency seems to reign as a priority issue. And I think that the reason is that's probably the thing we can impact first, right? How we directly pass legislation or regulate to lower costs is very complicated. So we're trying to work with our stakeholders to at least give patients information at its basic level. Know what you're buying. Know what you're walking into. You know, go to the clinic before you go to the emergency room. Help us contain costs. And we go back and we talk about, you know, outcomes. You're absolutely right. You can do everything right as a provider, and then they leave your office and you have no control over their lifestyle, right? You have no control over the choices they make outside of the confines of when you're meeting with them. I think what outcome-based programming is for follow-up, right? To kind of guide them as much as possible. I will say one thing, and it's incumbent upon everybody in this room. When we look at the issue of the environment, and we were like, we have a problem. We have a sustainability problem. We need to start recycling. Our resources are running out. The first thing we did was we identified schools and children to make the most profound impact. Teach them young so that they make recycling, conservation, reuse a priority. And that was the direction we thought we could make the best long-term changes. And we still work on high-level treaties with other countries on emissions and different things. If we use that as an example in this healthcare model, and I hate to keep going back to preventative care, but we need to model the behavior we want our children to have. I read a book recently, and its entire premise was people stop listening to what they're told to do at age 3. At age 3, they stop listening to what people tell them. They, at that point, will only model the behavior they see. Right? So if we're providers and we're community leaders and we go to elementary schools and we're telling kids, you got to exercise, you got to be active, and we're overweight and we're not healthy, we're drinking Diet Coke on stage. Sorry about that. My one vice. I think that we as a community should lead by examples, the leaders in our community, and be as fit and healthy and wellness driven as possible. Right. And I think that will multiply.
I want to pose one final question to the remaining 3 panelists, but before we do, just a note, we're going to open it up here after this question to audience questions in about 5 minutes, so just be thinking if you have a question for our panelists here. But I want to return to kind of your earlier point, which was it sounds like there is bipartisan, at least agreement on a starting point of let's talk about transparency. And to me, that means transparency in pricing, helping consumers of healthcare be informed shoppers. And to the other 3 panelists, if hearing that, what is a specific a policy recommendation for what transparency in health pricing should look like in Texas? Ms. Turley, I'll pick on you first just because we've talked about this a little bit, but from a provider perspective, what should transparency look like?
Transparency needs to be individualized.
So not online posting.
Transparency is not online posting of what my contract is with insurance A, B, and C for common procedures, because I would defy almost anyone to define what a common procedure is. And so I think from a policy standpoint, we have to pass policy or that really engages, if we're talking about insurance, the carrier. They are the one who has the contract with either the employer group or directly with the patient, and really engaging that carrier to better inform their consumer. I'm the provider. I didn't write the policy. And so I think it's, whatever we finally end up with, there's a lot more players who have a significant role in that than simply the provider and the patient.
Do you agree with that, Ms. Kirsch?
I wish I had the silver bullet here. I mean, I do think that the federal government, Texas has attempted on the TDI website to get information out there to allow folks to compare, like the price of an MRI, for example. Drug pricing to me is huge, and some of the increases we've seen, for example, in insulin, just kind of unconscionable to me, because if people don't get those medications to maintain their health, we're all going to pay higher costs, and they're going to end up with disabilities. So I think we have to continue to work on that. But I would say at the same time, I do think health literacy, and we talked about this a little bit, educating people not only about self-care, but also about how to use, insurance is super complicated. And reading an explanation of benefits from a hospital, from a doctor. So I do think we can continue to work to educate people about how best to advocate for their health. And that would go a long way too, along with, I do think we need transparency. I just don't have right now the silver bullet for that.
Mr. Willett, your thoughts?
Our system is pretty antiquated. Everybody in this room, I'd venture to guess, has a smartphone. It should be relatively easy to see from your carrier, from the hospital, what the real price is going to be, and that is the negotiated rate. The charge is a fictional number. we can have that access at the tip of our fingers. When it comes to cost, we have an affordability issue, and we've talked about that. So we not only need to see the transparency of what it is on insurance, but we need to see what the pricing is at the cash rate. My Uber driver on the way over said he takes an insulin drug, and he costs him $400. The only way he's able to get it is if he crosses the border and goes to Mexico. There are direct pharmacies here in Texas where you can get a vial of Humalog for $60. Those are just coming up in the marketplace, but we're starting to see more affordability, but it's outside of healthcare. Some of my colleagues at the foundation, they send me all of their pricing information because I'm telling them, ask the cash price. And I would implore everybody in the room, when you go to the pharmacy, ask the cash price before you use your insurance card, because you'll be surprised at the difference that you'll get in those numbers. But my colleague had a lab test with insurance. It was $1,200. If she paid cash, it was $250. We have a desperately broken system, and we need to inject some sanity and some reasonable market forces into healthcare. We've got to be able to know what it is. But transparency is not just for pricing. Being able to see quality, being able to see what infection rates are in hospitals, being able to see what mortality rates for certain physicians, being able to see how good someone is at a particular procedure before you go in and see it. Because oftentimes, healthcare is one of the few industries, if not the only one, where the higher the cost, the lower the quality. It has an inverse relationship. Usually your better quality providers are the lower cost.
So I'd like to open it up to audience questions. We have some microphones here. Folks can line up. I encourage you to line up at the microphone. I'll call on you. And I just ask that you introduce yourself, say your name, and please make sure that your question ends in a question mark, or else I have to cut you off, and it's just really awkward. So we'll start over here.
Thank you. Thank you very much. Leticia Van de Putte, former legislator, but pharmacist for 40-plus years. One of the things I would like to ask the panelists is your comments are fabulous. What I haven't heard is what Texas is notorious for, is not allowing everybody that's a health professional practice to the level of their learning. It took us 3 legislative sessions to have pharmacists be able to do vaccinations in the pharmacy, and you know that's been great successful. Optometrists to be able to treat glaucoma or minor effects. I haven't heard, but other states are having great success by allowing those nurse practitioners, physician assistants, dental, everybody in the healthcare to practice to the level of their learning. I know the RGV here and their medical school, and the model is that collaborative practice. Is there an opportunity for us to unburden our healthcare professionals in that team that would allow us not only better outcomes but lower costs?
So it's interesting I get several constituent doctor calls regularly throughout the time I've been in office, 14 years, that talk about their experience with pre-authorization, with reimbursements, with multiple issues dealing with managed care, and it's interesting. I'm a lupus survivor, and I was mentioning this before I got on. This was about 7 years ago, but it took me 3 to 6 months to get diagnosed because the doctor's like, well, I have to do process of elimination before we can diagnose you. And I said, well, I don't understand. Well, you know, he told me, I went to medical school to cure people, but once you get out into the real world, you're confined with how insurance structures how we practice medicine. So he explained to me that I can't just run a full panel of tests. I got to do it at the most cost-effectively way as possible. I was like, well, what about how I feel in the meantime? And he's like, I'm sorry, that's how we have to do it. So I had to have several tests before they ultimately found that I was diagnosed with lupus, and then they put me on a plan. But I'm one of the lucky ones. They found it in 3 to 6 months. What about other patients? And who get denied and have to appeal and have to keep going back, and pre-authorization doctors who pick up the phone to get a pre-authorization, they say no, they hang up, they pick it up again, and the next person at the same insurance company says, oh yeah, go ahead. So That's very interesting that doctors aren't practicing medicine like they were taught. It's very much watered down and structured based on how they get paid.
And I think part of the question is whether a change to some of the scope of practice rules could be a way of cutting costs. And I'm curious if you guys have thoughts on that as well.
I hesitate to even dip into scope of practice because that's a very political issue, I know. But certainly at the Dell Medical School, team-based care, people being able to practice to the top of their ability and training. We don't have enough healthcare providers in Texas. So I think we need to be using everybody we have, and we very much have that collaborative team-based approach too. I would go a step further. Advanced practice nurses, physician assistants, but also licensed clinical social workers. We're starting to see where folks like community health workers that don't even have a license can be an important member of the care team with the proper guidance and a team-based approach. So certainly very much for that. In terms of the specifics of scope of practice, I'll leave that to the legislators, but it's important.
There's more of a collaborative effort when it comes to scope of practice. And I have some colleagues here, Dr. Oliverson, Donna Howard, several others that serve in the legislature. And like telemedicine is becoming something we are promoting at the legislature significantly. Where we wanted them to be in person, now we're making access via this incredible online feed. We're trending in the right direction in that aspect.
We'll go over here for the next question.
Good morning. Richard Atkinson. I'm with Family Network. We're a nonprofit for families that have children with disabilities in Houston, Texas. Let me get here. Texas is ranked 50th last in healthcare access and affordability in the United States. Texas has refused Medicaid expansion, losing billions and billions of dollars of federal funding. What is your stand on the issue and why?
Yeah, so we can just go down the row, starting with Representative Lucio. Yes or no, Medicaid expansion, and a brief why.
Yes. Those are our state tax dollars, our Texans' tax dollars that are going to the federal government that we are leaving on the table instead of coming back to Texas to take care of our very own.
I would agree.
And I'm just speaking for myself since I work for a state medical school, but I would say yes for sure. And I would just note that this week, CMS is supposed to be announcing some new flexibility around adults, uninsured adults for states. And I do think that could be an opportunity for Texas, who has not expanded coverage for that population. Maybe that there's enough flexibility there that we might be able to get to a better place than where we are now. With the DSRIP funding going away and the Medicaid waiver, that population has been heavily served through funds that have been coming into Texas. And so we need to look for ways to keep those dollars in Texas so that people have access to primary and preventive care and other care.
I'm going to be the outlier here. I don't think Texas should expand Medicaid, because Medicaid was meant for women and children, and expanding will include a lot of able-bodied people above 100% of the federal poverty limit. So, and we've had here, according to the Census Bureau, we had tens of thousands of people that were Medicaid eligible, but were not enrolled. Well, if you were eligible for Medicaid, why would you not be enrolled unless the sense of value was just not there? We have a shortage of physicians that are enrolled in Medicaid. The strain and exacerbation on the system is dire. And so I hesitate, and I don't think that it's compassionate to crowd out the people for which that program was intended by bringing people that it was not intended for into the system. I think the reason that access is an issue is because we have an affordability problem.
And we could certainly have an hour-long discussion, I think, just on Medicaid expansion. And there will be plenty of discussion in the next panel, I assure you. But we'll move on here. Another question.
Hi. I'm Mary Horozakowski, retired from the practice of medicine in Minnesota and involved in healthcare research there about systematizing healthcare to improve quality and hopefully lower costs as well. And that issue of systematizing care, I think, touches on many of the points of discussion here. I've lived in the Valley now for 3.5 years. I'm a heavy user of healthcare because of chronic conditions. And I've repeatedly been surprised and baffled at the inefficiencies of care that I experience here. And it feels to me, looks to me like there's a lot that could be done to better systematize care and update it as well. A couple of quick examples.
Ma'am, I need a question. I'm sorry.
Okay, well, it's the question about what is being done to look at systematizing care and improving the quality of care overall, and particularly for chronic conditions. But thinking in relation to the kinds of inefficiencies that exist in at least multiple practices here in multiple systems.
Anybody want to take a stab at that, using systemization to improve efficiency? Ms. Kirsch?
We definitely need to do more of that. Texas is such a diverse state and such a big state and so many providers that, I do think we also have an independent streak where folks are doing their own thing. It's kind of part of our Texas fabric. Chronic care, one area where I would say I think Texas is making strides in some systematization is maternal care. I think that's an area that's been a heavy focus of the legislature in a bipartisan way that we need to be doing more for moms and babies. And you have efforts like the AIM bundles that are looking at making sure all hospitals have the right safety protocols in place if a hemorrhage or something like that happens in the hospital to prevent maternal mortality. I think there are some bright spots. Also, I'm going to mention mental health, the new Children's Mental Health Consortium that the legislature funded last session, where it is a collaborative effort, but with universities working together with others to try to have a better framework there. We have a long, long way to go. And on chronic care management, I think one of the challenges for Texas is you have Medicare, you have some adults in Medicaid, you have a lot of uninsured adults. So kind of how to bridge all of those programs to provide effective chronic care management is an added challenge, I think, with different payers.
I think we have time for one more question, and we'll go over here.
Good morning. Nice panel. My name is Jose Antonio Jerimba. I am an independent health researcher. I discovered that most of our health complication takes place inside of our mother's womb. 90% of humans are born with pre-existing conditions. If you have a short leg, a long arm, how can you be healthy? And I discovered a method to keep a human structure in permanent alignment and the body in balance. And to your panel, the question is, if we have a method that we can lower health costs by 60% to the Texans, would you look into it? Thank you.
Sure. I think nobody here is going to say no to a way of cutting costs by 60%. I think would be worth looking into.